Hi, thanks for joining us at Student Nurses Success as we're continuing our series on respiratory disorders. This particular map is just kind of all the leftover respiratory disorders that we couldn't fit into the other categories, but they're still important to know. So we're just going to kind of finish up our respiratory series with this final map. Let's go ahead and begin. Remember, the link to the maps is in the comments section. We're going to first begin with pleural space disorders, and there's actually three that we're going to, well, maybe we'll call that four that we're going to talk about. First of which is pleuritis. Pleuritis is really just inflammation of the pleura, and it's a very common with any type of infectious process. What we see with manifestations is really just pain in the pleural area. And so you can have pleuritis when you have pneumonia, maybe you've had maybe just maybe a frequent cough or cold or something like that. So pleuritis is really just kind of a general definition for pain in the chest or chest pain. However, the real question with pleuritis is the pain angina related to chest pain, or is it pleurisy related to some respiratory problem? And that really does need to be teased out. Usually, pleuritis or pleurisy, we see pain is unilateral on one side, and it tends to be with movement, cough, or breathing. However, it all should be investigated because you don't want to just say, oh, it's just pleuritis when it is angina or chest pain related to some type of cardiovascular event. Now let's talk about pleural effusion. And let's make this just a little bigger here. Pleural effusion is a collection of fluid in the pleural space. Remember, there's kind of layers to the lung, and we call that pleural space. And there's a tiny bit of fluid in that pleural space all the time because it kind of helps decrease friction and kind of helps with inflation of the lungs. However, sometimes you can get an accumulation of fluid in that pleural space, and that would be called pleural effusion. It usually results from another disease process, whether it be maybe pneumonia or tuberculosis or some type of infection, or sometimes it can be related to some type of lung cancer. So really the question is, what does the fluid consist of? And so tapping that through a thoracentesis, which is a procedure to pull that fluid out, taking that fluid out, testing it and seeing what's in it will give us a lot of information. If they find dysplastic cells, then there may be a cancer nearby. If it's just bacteria, then it could be from pneumonia. Manifestations of pleural effusion, it really depends on how big that effusion is. Often they're just not too big. It's not that big of a deal. We just let time kind of take over and let it reabsorb. However, if the effusion is large, we can develop dyspnea, pain, even cough. And if it's really impacting the lungs and taking up a lot of space, you're going to have decreased breath sounds when you listen in that lower lobe here where the effusion is present because air would not be moving in and out during the effusion. So our last two in this, I'm going to kind of couple them together, pneumothorax and hemothorax. What we have with pneumothorax is air in this pleural space, okay? Or if it's a hemothorax, it's blood that is collected in that pleural space. And you're probably thinking, well, what's the difference between that or pleural effusion? Pleural effusions tend to be smaller amounts, whereas pneumothorax, hemothorax are either air or blood, and they generally are in larger amounts and they're more impactful. So pleural effusion's more some type of other fluid, maybe from a inflammatory process or maybe from cancer. So the difference to pneumo, air, hemo, blood. What happens is that in both a pneumothorax and a hemothorax, there's either a partial or a complete collapse of the lung. And this is due to the loss of negative pressure in that pleural space. Because we are taking up a larger portion of the pleural space with either air or blood, we lose that negative pressure, which keeps that lung inflated. So that lung, if you see here, is really tiny. I'm kind of outlining it for you. And it really impacts, we kind of actually, the lung kind of, we might call it, it just kind of goes down and deflates. There can be a couple causes of a pneumothorax or a hemothorax. They can be spontaneous from coughing. If you have a really bad cough or coughing really hard, you can get a spontaneous pneumothorax. Usually wouldn't get a hemothorax from that. It could be traumatic from injury, maybe a gunshot wound or a car accident where you have a rib fracture that punctures a lung. If it punctures the lung, it may just be air that goes in there. If it punctures a vessel, it may be blood that collects in there. And it can also be iatrogenic from a medical procedure. Sometimes in the ICU, when we insert central lines, everyone's anatomy is a little different. And if you nick something with the needle, you can cause a pneumo or a hemothorax. Manifestations are going to include a sharp, intense pain, and there's going to be difficulty breathing because you're actually going down to just only one lung breathing. And so you're kind of half workload there. You're not going to hear breath sounds on the side that is affected because there's going to be no air exchange because that lung is deflated. And the trachea is probably going to shift over to the opposite side. So you're going to see that trachea push down. So let's just say this is your left and right. We'll label these. If you have a right pneumothorax, you are going to see a deviation of that trachea to the left side. Treatment for this will be a chest tube. You'll learn how to take care of that in your other nursing courses, but that will help you either drain that blood or fluid, or it will help re-inflate that lung. Now let's move on to pulmonary vascular disorders. We're going to begin with pulmonary emboli. A pulmonary emboli is really material that is from the venous system that actually gains access to the pulmonary circulation and lodges in the pulmonary circulation. And you can kind of see a little picture here. Most often it is a blood clot. And this blood clot is commonly from a DVT or a deep vein thrombosis that develops usually in a patient's leg, often when the patient has been immobile for a period of time. It can also be air and it can also be a fat emboli, but most commonly it would be a blood clot. So what happens is as this clot breaks loose, it gains access to the peripheral circulation, and as that returns to the heart, it moves through the right atrium, through the right ventricle, into the pulmonary artery, and will lodge in the first smallest vessel that it gets stuck in, and that is usually in the lungs. Now, what we see is reduced perfusion. We can still get air in and out, but what we're not seeing is gas exchange because the clot is keeping blood from moving through and doing gas exchange at the level of the alveoli. Patients usually present with a sudden onset of acute chest pain because of the ischemia from the clot. They may develop shortness of breath, decreased breath sounds, and even respiratory failure. I'd also like to talk about pulmonary hypertension. Pulmonary hypertension is increased pressure in the pulmonary vasculature. The pulmonary circulation should really be low flow. It should not be high pressure. When we're talking about pulmonary hypertension, this is not something like your systemic blood pressure that you can check with a blood pressure cuff on your arm. This is actually the pressure inside the lung vascular system. There's lots of different causes, and sometimes we may not even know what causes it. Sometimes it can just be idiopathic. You just have too high of pressures in your lungs. Sometimes it can be caused from increased left atrial pressures or left-sided heart failure that backs up into the lungs and ruins the pulmonary circulation. It can be from cor pulmonale, which we'll talk about down here. We've kind of got that. And it can also be from lung disease such as COPD. That actually causes the lungs to become very stiff, and that can ruin and increase the pressures in the lungs. What we see is as the pressure inside the pulmonary vessels increases, they become very thickened and fibrotic. And over time, then that is going to decrease gas exchange and oxygenation. Patients with pulmonary hypertension will develop exercise intolerance, maybe even fatigue and fainting, also known as syncope. They may have difficulty breathing because the pressure in that lung is so high that backs up, and it may actually cause right-sided heart failure symptoms and also chest pain. Now, cor pulmonale is the development of right-sided heart failure from lung disease. When we have lung disease, that fibrosis and hardening of those lungs that develops with COPD will make it difficult for blood to move through the lungs. And so that blood starts to back up into the right side or the right ventricle, and we call that cor pulmonale. So it's really very similar to right heart failure. Let's move on and talk about lung cancer or lung malignancy. The main causes are smoking and industrial hazards. There are four main types. Certainly, there's subtypes under these. Small cell lung cancer is highly malignant and spreads very, very quickly. We know that large cell also spreads very quickly. Squamous cell is most closely correlated with smoking. It is probably a little bit more common than the other two types I just talked about. And adenocarcinoma in the lung is often found in the peripheral parts of the lung or more the outsides of the lungs. We also know that lung cancer can be from a metastasis, and most commonly breast, pancreatic, kidney, and skin cancer metastasize to the lungs. With lung cancer, it is often asymptomatic until it has spread, which is going to reduce prognosis. We know that patients, when they do start to develop cancers, difficulty breathing, cough, maybe chest pain, coughing up of blood, hemoptysis, and even hoarseness. Depending on where the tumor is, it can press on other structures in the thoracic area, and you can develop what we call extrathoracic manifestations from that tumor pressing on things. That may include maybe increased blood pressure and even facial swelling. And then also, we know weight loss is correlated as well with all of our cancers. Atelectasis can range from kind of mild to severe. Really, atelectasis is when the alveoli become blocked or collapse and they cannot open and expand. If you cannot get air into your alveoli, then you can't have gas exchange. For infants, the biggest cause is probably premature infants and the lack of surfactant, and those alveoli can't expand. And we know that leads to respiratory distress syndrome. We covered that in our pediatric respiratory video. In adults, you can get atelectasis from mucus plugging and then the alveoli deflate, or maybe if fluid accumulates in the alveoli from pneumonia. If we do have atelectasis, we know that since that is the location of gas exchange, patients are going to be hypoxic and have decreased O2 sats, and they may also have respiratory distress. In mild cases of atelectasis, we know that ambulation and deep breathing can really help kind of reinflate those alveoli. And so those might be great nursing interventions in situations where people are maybe immobile and we're really trying to get them up and moving. Our last two I'd like to talk about is acute respiratory distress and acute respiratory failure. And I'm going to kind of talk about them together. Now, acute respiratory distress syndrome is really acute pulmonary inflammation. Um, it includes both respiratory and ventilatory failure. What we see in acute respiratory distress syndrome is there's some type of epithelial injury and it causes an inflammatory response. Fluids and plasma proteins kind of move into those alveoli. It's more of an acute, quicker onset from maybe trauma or very serious illness. And as that inflammation continues, the lungs become stiffer and non-compliant, and we see reduced gas exchange. Now, acute respiratory failure is really more of a general overarching term, and ARDS is one cause of acute respiratory failure. With acute respiratory failure, there's that inability to oxygenate, and you do have abnormal ABGs. It is the result of disorders that cause hypoxia and hypercapnia. So, where ARDS is more of kind of an acute inflammatory injury type of cause, acute respiratory failure is kind of an overall inability to oxygenate the body. We see chronic lung disease such as COPD or other lung diseases being causes of respiratory failure over time, ARDS also being a cause, and even neuromuscular diseases such as muscular dystrophy, ALS, chest wall disorders can lead to respiratory failure over time, as well as obesity. That does it. That should wrap up our respiratory series. We've covered them all. Make sure that you view our other respiratory videos in order to uh, cover infections, pediatric issues, and chronic respiratory issues. Thanks a lot. We appreciate you coming to see us on our YouTube site. Remember to like and subscribe to keep up to date on all our videos.